Okay, welcome back everybody to our plenary session. We actually have a wonderful plenary speaker that agreed to come here. We're lucky to have Julianne Pollard Larkin, who is a medical physicist at the MD Anderson Center in Houston. She got her PhD at UCLA in medical physics, and I thought this would be a great opportunity to hear a little bit different topic in physics. She does research in the Cancer Center in Medical Physics at Houston. She is very interested in outreach, and she was excited to see us playing with toys earlier. So she is one of us. She's a person that's into education, and so she's going to give us a great talk on medical physics. So let's welcome to AAPT, Julie Pollard Larkin.
Firstly, thank you so much for this wonderful opportunity, especially for all the people that reached out to have me come here tonight, from Dr. Gordon Ramsay to Dr. Tony Sansi, all the way from TLU, the TLU crew who actually probably brought me to attention of AAPT. Thank you all for even being here tonight and for taking time to hear about a very different topic than I'm sure you guys probably talk about all the other times. This has nothing to do with astronomy or basic physics. We're your applied sisterhood, if you will. And so I'm going to talk to you about some of the new things going on in my world, which is part of your world as well. So I'll give you a background of our history, talk about what we're currently doing in clinical medical physics, what's going on in MD Anderson's radiation oncology department, and then show you something new, what's coming up and will be utilized for treatment, hopefully within the next 10 years. And then for those people who want to let their students know how to join us, because there's specific steps that you can take to help educate your students so that they can one day become the next Dr. Julie. So I want to let you know I will be talking about a lot of different technologies coming from very different vendors, but I have no connections with any of them. None of them have paid for me to be here. So I'm not trying to sell you a LINAC. Please believe that. But I will show you a lot of them, and you'll want to buy one. All right. So let's jump into it. Let's talk about our history. So most of us probably have heard of Sir Rankin, and he was the one who actually, not was the first to actually see X-rays, but the first to totally characterize them. After that, he was awarded the Nobel Prize in Physics in 1901. And if Sir Rankin was the father, guess who the mama was? That was Marie Curie. She, alongside her husband, Anne Becquerel, helped to describe radioactivity. As a group, they received a Nobel Prize in physics, and then in chemistry, she won one as well in 1911. She is the first and only person to have 2 Nobel Prizes and then to have them in different areas of expertise. So after that period of time, it became the golden age of radiation. People started to get super excited. It was discovered in 1895, and guess when it first was used for medical use? 1896. Not too many months after the discovery. The first X-ray that was taken was, of course, of Rankin's wife's hand, and when she saw it, she gasped, clutched her pearls, and said, "My God, I have seen my own end." That's what she said. Why? This was the Victorian era. Let's start to think about what that was like back then. They were all clothed up, right? They were wearing big gowns and girdles, and everything was covered, and they were very religious. And then what happens with the X-rays? Everything is gone. And you can see beneath. My God, that is amazing. So now people were excited, and all of a sudden they're using X-rays for so many different things that you would never do today. Do you have a headache? Do you need relief? Well, guess what we have for you? You can try Kohler's antidote, and also known as X-ray exposure. Ladies, if you have extra hair on your chin, guess what? We've got radiation for that. Yes, they used it for so many purposes that we would never think of today, but as soon as we started to do this and get unyieldly with our use of radiation, so quickly did we learn the double-edged sword effects of radiation. Yes, it's good for treating tumors and things that are right underneath the epithelium, but then they also can cause significant damage if they're used in an unwarranted manner. So very quickly we became aware of how dangerous radiation was, but no one learned quick enough to stop this from happening to Sir Eben Byers. Now, you may not know the name today, but if you had been alive back in the 20s, in the Roaring 20s, oh, he was part of the roar. He was the gentleman that was the playboy of the day. He was virile, he was strong, he was rich, but he had a little secret. Yeah, it came from radium water. And as he took it so much, guess what happened to Sir Eden Byers? His jaw fell off, and he died. This is real. I didn't make this up. And this really happened. So we realized over time we need to be more pragmatic about how we use radiation, right? So already in the 1950s, the Canadians, very smart group of people, they came up with the idea of saying, you know what? Instead of just giving radiation to large sites of the body, what if on the same surface that we actually give the radiation, we have an imaging device that's coupled to it and allows you to see where we are treating before we deliver the curative dose. Whoa, all of a sudden, we have a whole new paradigm for how we want to deliver radiation therapy. And it was started in the late 1950s that people started to realize the necessity to know not just how much dose am I giving, but to where, because of the effects of that radiation. So all the way in the 1950s, the late 1950s, with the first linear accelerator that was in the Western Hemisphere, Stanford started doing what's known as double exposures, which we still utilize today, where you get a big shot of an X-ray of a patient's normal anatomy, and then you show a focalized view of where you intend to deliver dose. And so in 1956, they unveiled their first LINAC at Stanford, noticed the sheer size of the gantry and the setup for how to keep the patient still, and then imagine the magnitude of having to lay still while everyone runs out and you have this 20-foot edifice hanging right above your head. So in the 1961, the Netherlands, another wonderful place, they finally brought Canada's dream to reality. They had the gantry on a rotating column that still had an imager also and coincident with the isocenter for where the dose would be delivered. Finally, in 1961, we were both able to treat and see where we're delivering the dose in the same position and the same time for the patient. This was amazing. And I want you to understand, the geometry didn't change much. You saw from 1961 in the Netherlands to today, 2012, and the MD Anderson's Proton Center. Notice you have the same rotating gantry with the nozzles pointed right here for where the patient should be, as well as imaging panels that come out from this back side. So from the first LINAC in 1956, notice this really almost depressing image of a child that's being treated, but I want you to note, he did survive. They cured his cancer, even with that kind of setup, with nothing holding or supporting him. And today's current proton treatment for a child in almost the same exact position. I think they did that just because they realized how iconic a shot of that first kid from 1956 was. And so what I want you to understand, the whole progression that I showed you from the early 1900s to today, 2012, we were using IGRT to help to improve our treatment, to help make them more detailed and refined, so that we moved from having the rudimentary blocked treatment fields that we used to have, oh God forgive me, to the actually characterizing a new way of delivering dose so it more closely matches the real person that we want to treat. So IGRT, now that you have an idea, you can sort of tell when you're not getting it, can't you? You can see that this cat isn't really giving you the CAT scan that you were looking for. So when we talk about image-guided radiation therapy, we're referring to having in-room imaging guiding the radiation delivery based on instantaneous knowledge of the target location and any changes in the tumor volume during that course of treatment. So the goal of IGRT is to help to reduce the uncertainties that are inherent in radiation therapy, which includes setup variation, internal organ displacement, volume changes and deformations. There are all these things that go on with trying to align the patient day to day that we have to limit. And so one of the ways that we do this is by getting imaging information at the time of treatment. So this helps to show, in a nutshell, a very basic principle. When you breathe, your internal anatomy moves with your diaphragm. This makes treating your lung tumors super hard for this person right here. So we have several different techniques. One way is to actually acknowledge and to measure the extent of motion of said tumor within your lungs, or to actually come up with ways of having you hold your breath such that you actually stop this motion, and then we image to prove that the tumor is where we expect it to be. So IGRT has gone through a whole long course of history of actually increasing complexities. We started off with just basic 2D type of imaging. You had ultrasound, KV radiographic films, portal imaging, and markers that you can actually implant into the tumor. And the type of images that you get from them show you the ability to help to reduce margins. Notice that when you're looking at the MVCT right here, you're not getting as well good soft tissue contrast as what you're getting with the KV cone beam CT. And so the very nature of the type of IGRT that you have available on your machinery typically will dictate what type of high-dose treatment regimen you can offer with any type of confidence. And so in the current radiotherapy LINAC vaults, what you'll notice is a beautiful room much like this, where you're going to have a skylight, you're going to have nice wooden paneling and so forth to help to work upon making the patient feel more at home, despite being underneath a gantry with, 6 megawatts of power being forced through it. And then you also will have other types of panels which will allow for the therapists who are delivering the treatment to set up the patient and to monitor any type of tumor motion within the patient as they deliver the treatment. And so here's another beautiful vault. Notice that they brought in some greenery. I wish we had that at my particular center. And so there's a whole array of different devices that offer radiotherapy treatment, going all the way from surgery, stereotactic radiosurgery units, such as the Novalis, to the TrueBeam, which happens to be one of the most quickly bought and utilized linear accelerators right now on the market. Lots of places are throwing out their older school Varian Linacs and bringing in TrueBeams. Then, of course, tomotherapy units, and then nucleotrons, which offer brachytherapy. And there's a whole wide array of different types of treatments that we offer, but most are going to be linear accelerator-based, such as that TrueBeam. The Gamma Knife is a unit which allows for you to treat stereotactic radiosurgery type lesions within the brain. So the patient would be lying on that table. Notice that little steel frame at the end of the couch. That's where the head of the patient gets locked into in a stereotactic frame to allow for precise targeting of the lesions within the brain. And so at our particular center, there's a whole bunch of Julies. There's over 60 therapy medical physicists, just therapy alone. Then we have, outside of us, over 20 imaging physicists, broaching on about 30 of them. And then, remember I was telling you about all those linear accelerators? We have roughly about 17 of them at our main campus alone. And then at our area sites, we have 7. If you wanted to know what the imaging department looks like, this is a shot of them from about 2 years ago. And notice this is just having about 30 or so faculty. This is why I don't have the full picture of my therapy physics team as well. And so when it comes to radiation physics or medical physics, we have a host of responsibilities. We aren't just faculty. We have to continue and do our clinical practice. Most of us, especially myself, we have an 80% contract, which means that 80% of my time is dedicated to clinical treatment, meaning I am treating patients, carrying out all the measurements that need to be done in order to make sure all those uncertainties that I talked about get measured well. Then I'm supposed to, with the last 20% of my effort, do research, education, and when we talk about education, it's not just for the graduate students in my program in medical physics, but also you're teaching the residents, so that includes the medical residents. Yes, the medical doctors in our institution, we need to instruct them on the safe and effective use of radiotherapy, as well as undergrads and so forth. Then on top of that, we have general requirements that we have to assist with as well, and even safety measures that we must look after as being an ethical medical physicist. So when it comes to external beam radiotherapy, the hallmark of what allows us to do that at our center and worldwide is the linear accelerator. What you'll notice is that it has that beautiful gantry with the electron gun, the gridded electron gun at the back, and it shoots that beautiful electron beam along the standing waveguide. Then it gets bent by 270-degree bending magnet, and then shot through this portal, which will connect to either scattering foils or flattening filters, depending upon what type of beam you want to treat with. And then once it goes through the ionization chamber to actually let us know how much dose, how penetrating is this beam, it calculates that. Then it also goes through shaping jaws, which will help to shape the beam in a rectangular fashion. And then ultimately, it has MLCs down here, which help to even more finely shape the beam in a three-dimensional dimension. So there's a whole bunch of different types of linear accelerators that we have available to us right now. And what I will tell you is that most people use Varian Linacs, such as my particular center, and the hallmark of what we typically are bringing into our facility is the True Beam, which is the latest model of the Varian Linac that they have available. Notice that they also have a lot of older school units, which you will still be seeing utilized at other centers, which are just as good. It's just that when it's time for replacement, which usually takes about 10 to 15 years, the True Beams are replacing all these older units. Now, if they aren't a Varian center, then they're probably going to be an Electa center. Electa would be that second choice for you if you wanted to use a different vendor. And one of the latest Electa units happens to be the Versa High Definition Linear Accelerator. And what's notable about their linear accelerators is that they give you a false impression that they're half the size. Why? Because you see the entire portion of that standing guide all pushed behind the wall. So all you see is the rotating gantry rotating about the patient. This is great for psychological reasons, and it helps the patient feel as if there's less things imposing upon them. And what I really love about the Versa High Def is that it glows blue in the dark. I have to admit, that's the one nice thing about it, that they put those little strobe lights on it. The reason why we utilize radiation is because it works. When you combine radiotherapy with hormonal therapy, chemotherapy, and surgery, we help to synergistically improve outcomes on patients. So roughly 70% of all patients that come through a cancer center, guess what? They're gonna get some radiation therapy. And so this is probably one of the best kept secrets because most people don't even know about medical physics. They've heard about radiation, but the truth of the matter is that radiation works, and that's why we're having a big push to increase our numbers of medical physicists. At our center, we also have a proton therapy center. Here's a picture of our former chair of our department on the medical side. This is Dr. Jim Cox standing in front of the cyclotron from the Proton Center right before it was unveiled. Here is a beautiful shot of the actual gantry with the patient getting ready for treatment. Notice the gentleman standing, holding on to that floating remote control happens to be the radiation therapist who assists and actually delivers treatment day to day with the help of the medical physicist. This is one of the patients, one of our pediatric patients at the Proton Center finishing her treatment. And you'll notice if you go to most cancer centers, most people ring a bell when they're done, right? We got those bells, but guess what? Because Proton, how much it costs and everything, we had to get bigger, and it is Texas. So we brought in a gong. They brought it from Japan, I believe. It's crazy, and somebody actually broke it. That's how excited they were, and we actually got another one. So if you ever, God forbid, have to come there, hopefully it's for research, check out our gong. Say, Julie talked about it. I want to see it. So some facts about our Proton Therapy Center. It opened in 2006, and we were the first to use an intensity modulated proton therapy, which in a way sort of simulates the beautiful 3D, really extra 3D conformal techniques that we use for photon, known as IGRT. We were the first proton therapy center that was established within a comprehensive cancer center, and our youngest patient to date was less than a year old. We've treated over 6,500 patients, and we've moved from treating just 4 different types of cancer to 8 different types. And so over the course of time, we went from just 41 patients in 2006 to over 800 consistently for the last couple of years. We've moved from treating just 4 different sites to now having a plethora of different disease types being treated, from breast, CNS, GI, GU, head and neck, lymphoma, PD, sarcoma, and thoracic. So the reason why we utilize proton therapy is because it helps to maximize disease control, improve overall survival, minimize both early and late-term side effects, preserve organ function, and preserve quality of life. And the most important thing, eliminating unnecessary radiation to the patient. I'm going to show you some diagrams that actually will help you better understand that. So you need to understand that one cannot have a radiation-induced side effect in tissue that does not receive radiation. Now I'm going to show you some images showing you just what proton therapy looks like compared to 3D conformal photon therapy. Here we have some photon or X-rays that are being used to treat this mediastinal tumor. Notice that you have a wash of blue, which indicates light dose being in the lungs on the contralateral side, as well as the hot epicenter where we're getting the prescribed dose. Notice as you move into IGRT, you're getting an even more conformal shape to that high dose region, that red region. It's all confined within the target. Then we moved into the world of VMAT, getting even more conformal, but you notice we still have that blue wash of low dose extending beyond the area where we want to treat. Now we move into protons, and you'll notice that you only see dose at the entrance and exit, at the entrance beams. No exit dose. Whoa. Notice the beautiful part about protons, they stop. This is why people pay the big bucks for them. This is the difference. This is the rub. This is the reason people flew things from Japan to our center, just so that they could utilize this fact. And now that we've moved into the world of IMPT, forgive me, notice we're getting even more conformal shaped dose delivery and even less entrance dose spread to the other sides where the normal tissues are. So this has a big impact on what we believe to cause reduced amounts of late-term effects because we're not giving low dose to other areas unnecessarily. So the future of proton therapy, notice that as we progress on now, we are now moving into the era where we're just doing IMPT. We started off just like photon therapy, where everything was very 2D, basic block type of fields. Then in the photon world, IMRT came up to date in the late 90s to the 2000s, and that's when that took off. Whereas when it came into the proton world, we didn't start to have IMPT until much later, into 2015. And then we got to see the advancements and the improvements and the outcomes of what we see with proton therapy. So it's going to take a decade or more to see the true biological impact of having IMPT being utilized more often for patients. So when it comes to particle therapy facilities, we aren't alone. There's 53 currently in operation. So those big yellow stars show you where you can go to have any type of particle therapy. And then believe it or not, we're about to double in a number of years because 43 other centers are on the books for being brought up. And notice where it's all happening in the highly industrialized areas. So this is what it looks like. Isn't it beautiful? And it probably looks just like that right now. Texas sure looks good. That's the Proton Center, just the Proton Center by itself. And so the reason why we like proton therapy, and I tried to say it a couple of times before, is because of the fact, the way that it delivers dose. Because it is a heavy charged particle, when it comes in like a hot knife and warm butter. It slides in, not giving too much dose to the entrance, and then depositing all of its dose at the deep-seated target and delivering maximal dose there at the target, and then on its way out, delivering very little, that Bragg peak. That's what we are utilizing. And the heavier the charged particle, the better it gets. Heavy charged particles have high linear energy transfer, meaning that they can actually destroy and cause more double-strand breaks in the targets that they hit, much more preferable than low LETs such as X-rays, which aren't charged. So when it comes to heavy charged particles, protons aren't the only things out there. I want you to understand people are trying to get more and more exotic and trying to figure out other things that they can utilize. And so we are going to see a wave of different charged particles. But one thing holds true. The same process for how we do radiotherapy, regardless of the particle that is creating X-rays, electrons, protons, whatever, there is still a very simple process that must go on in order to allow for us to go about doing treatments. First, you have to have a diagnostic imaging scan to actually diagnose and say a patient truly has cancer. Then a doctor, the MD, the radiation oncologist, will determine what type of radiotherapy treatment options are available and give a prescription. Then we get to move in, do a simulation, do target definition, create the treatment plan. This is done not just also by physicists, but by people known as medical dosimetrists, which is a career option for some of your students. Then you have to do plan review and approval. That's typically done by the medical physicist. Pre-treatment QA, once again, medical physicists. Setup verification done by our radiation therapists. Those are the wonderful men and women who are actually trained in how to set up patients, and they do the treatment delivery as well. And because of all those steps, we actually take it even more seriously when we offer very specific types of treatments, such as SBRT. This is what I specialize in. This is what my team actually does day to day. Stereotactic body radiotherapy refers to actually giving a very highly conformal ablative radiation dose to deep-seated tumors in lung, liver, spine, and etc. When I say highly and conformal and ablative, the typical radiation treatment will give about 2 gray per day. And even if you don't know what that number means, when I tell you what SBRT gives, it's multiply that by 6. That's what I'm doing every single fraction with my lung thoracic patients. And so because the stakes are that much higher, because I am giving so much more dose, I have to be that much more confident and reduce all those uncertainties that I discussed about 20 minutes ago even more. So for my SBRT treatments, what I have is secure patient immobilization, accurate repositioning from that simulation scan to the treatment, reduction of the normal tissue exposure and that patient, and then rigorously accounting for any tumor motion, making sure that I stereotactically register tumor targets, and that I have a truly ablative dose fractionation scheme. When I talk about rigidly immobilizing a patient, we have these devices that we call cradles. And it doesn't look like the kind of cradle you're probably thinking of if you have children or ever had any, but it does the same thing. It holds them in a sweet position and hopefully lulls them to sleep. So this purple bag, it starts off as a bag. We actually vacuum seal it around the patient, and so I call that SBRT couture. Some of the patients think that's cute. I'm glad I got a chuckle, glad. And so it only fits them. Any other body, literally any other body, won't fit. You must have quit, all right? So you can't get, oh, I love y'all, all right. So once they get in that position, then I feel great. But because I'm a physicist, I still don't trust them. Then I have marks on that patient. They notice that you can see some purple marks here on the abdomen, right about there, which indicate whether or not the patient is rotated when they're in the cradle in the proper way. And then I have actual marks on the cradle, and if you were to see them from the top of their chest and so forth, they also have marks on them, so I know whether or not they're longitudinally displaced correctly within the cradle. But of course, that's just grossly in the right situation. Next, I'd have to do a cone beam CT scan and then assess where the tumor is. When I come up with the treatment plan for said patient, I will create a plan utilizing as many beams as possible to minimize dose to other normal tissues nearby to make sure I have a nice hot epicenter where I'm getting 110 to 120% of the dose to that tumor target. Because one of the things that I care about is making sure that I obliterate whatever is at that, whatever is coincident with all those beams. That is my sole purpose. That's why IGRT for me is critical to my existence, because what I do is deliver such a high dose that if I am wrong, literally 5 millimeters, I am impinging danger and I'm going to cause rib fracture and God knows what in that patient. So when it comes to actually coming up with these treatment plans, we've moved from our old school 3D conformal beams, which were much larger blocks shaped more loosely than what we have now, to IMRT, where we got to have more finely detailed beams that are being shaped by the MLCs, to now VMAT, volumated arc treatment, where you're actually allowing the IMRT beam to change dynamically while it goes around the patient in an arc, which until you see it, if you stand by me, coming by, if you ever come to Texas, I'll show it to you. It's gorgeous. This does not do it justice. What I will say is if you wanted to know, what do you see every day, Julie, when you treat patients? This screen. So this is the Variant 3D matching screen. What you'll notice on the left-hand side, you see all of the beams that are moded up to deliver patient treatment, and then you have an actual shot of the room, the actual treatment vault, looking feet first at the patient, so I can see at any point in time if they move, if they have an issue, if they're about to fall off the table, or they got up and left once I left as well. It can happen. Notice you see the true beam as well, obviously around them, and then you see the imaging panels coming out as well. So here's the detector, and here's the KV cone beam CT unit as well. And after I take the cone beam CT, I get to compare that to the reference CT, which happens to be here, and I can see in 3 different views: axial, transverse, axial, longitudinal, and coronal views, to see where the tumor is lining up to. And then I can determine how do I want to move the table, which moves the patient, in such a way to make sure that I'm treating only the area that I want. Once I figure out what that shift that I need to apply to the table is, then I can actually apply that shift, re-image patient, beam on when I feel confident. But not just me, when the doctor feels confident as well. So everything depends upon what type of surrogate I use to determine whether or not to beam on. So at simulation, we get that first planning CT scan of the patient where we identify where the tumor is. Then we're going to actually, on the day of treatment, get the patient to have the skin marks line up to where we want, then image the patient, and you'll notice the bones look great. But wait a minute, if you look at the isodose lines, even if you don't know what they mean, you notice they don't look the same as they did in the reference scan, hence meaning that they are now breathing differently today than they did at simulation. So this will obviously mean, don't treat like that. you've got to shift. So even if you've never done it before, you too can point out errors before they occur. And so what you need to understand, the reason why we do those cone beam CTs and have the 3D matching tool is because if all we did was how we treated patients back in the 1950s, just set them up on the couch and only perhaps use skin marks, notice how far off you can be if all you did was say, okay, let's line the skin marks up to the lasers in the room, which we have to help us line up. You'll notice the patient's anatomy, internal anatomy, is completely off, out of kilter. When you actually set up based upon the anatomy, then and only then can you confidently say how the patient should be aligned. So after we set the patient up and we feel confident with what's gone on, then we use what we call the record and verify system to converse with the physician, who's most likely at another room, and let them see how we've aligned the patient. After the doctor is happy with the way that we've aligned, they let us know by either approving said image in the record and verify system or by putting a nasty little red arrow saying what we should have done. But it's really important that we have this communication, because if they didn't say, then don't be upset when you see your patient the next day. So one of the reasons why we do SBRT is because it is beautiful at improving local control, local regional control, overall survival, and everything else, in especially the lung. And so that's all that I do. And so you'll notice SBRT is the nice little blue graph, whereas the wedge resection, which is surgery, don't tell any surgeons. I know some of you may know some surgeons. Don't say that you heard my talk. I want to, because actually this is the war that's going on. Finally, we are getting data to show that SBRT is finally being seen as equivalent to surgery. Whoa. That, when it came out, 2015, you should have seen the wars. And it's still going. It is still going. Part of my role as the medical physicist, as part of the SBRT team, is to minimize errors in the patient setup. So all of that shifting that I referred to on those screens beforehand, I literally write down those coordinates, how much I shift, 3 millimeters this way, 2 millimeters the next day. And I actually look to see if there's any type of systematic uncertainty that needs to be corrected. How do I look for this? Well, as I write down the numbers day to day, and literally this is what we do as an SBRT team, we check to see is there random error, which you cannot stop, such as peristalsis in the abdomen and so forth, or is there a systematic shift of that patient? Then that can mean that we are locking their cradle that we talked about, which holds them in place, in the wrong location on the treatment couch, or something else is going on. Maybe there's a pillow that's been applied that should not have been applied underneath the patient's hips or something. So these are the types of things that we look for, and literally millimeter range. And so on top of looking at just the day-to-day variations of the patient, sometimes we need to adapt the treatment. Sometimes the patient changes in such a way that it lasts and it persists. And if we don't correct the treatment plan, then we will continually to treat the patient incorrectly ever since that change takes place. So range variations are, they're nasty for protons. Why? Because what's so special about protons? Why do we like them? Because they're heavy and they're charged and they deliver dose and they stop. What happens when that tumor shrinks? What happens when the tumor changes? And if you're delivering the same static treatment plan day after day after day, and the patient's tumor has gotten smaller and smaller and smaller, and you didn't change anything, now you are killing that heart. And so one of the things that we do now as a current thing, not just in the proton world, even in photon world, because there are gross changes that can occur there as well. And that's why photons are a little bit safer, but that's a whole other discussion. We have to make sure that we validate and image the patient, use IGRT, not just to see the setup, but to check on changes that would require adapting the treatment plan and changing it to match what's going on with the patient. On top of that, not just looking at patients changing with their tumor and so forth, patients are difficult to treat because they have sometimes beautiful little devices implanted in them that can cause them to have strokes. Excuse me. If they happen to be in the presence of high EMI, or electromagnetic interference, such as a linear accelerator. So other projects of mine include actually detailing how to prevent, excuse me, how to prevent any type of single incidents within implanted cardiac devices in any of our thoracic radiotherapy patients. Because believe it or not, we have about 500,000 patients per year that get an ICD implanted or a pacemaker. These people are preferentially the highest group of people that we see coming through our clinics. And when we're treating patients, I tell you, probably about 10% of them are gonna have an ICD or a pacemaker. And then because of that, I need to be able to show whether or not the type of treatment plan that we are presenting for them may cause them to have any type of single event upset, which would prevent their device from working in an instance when it needs to. What my research has shown in a group with other physicians is that there is a chance of having some type of single event upset. Thank you so much. A single event upset only when you have a neutron-producing radiotherapy being delivered to that patient, meaning if it's over 10 MV or above, such as protons and so forth, then you may end up with that type of effect occurring. If you're delivering regular 6 MV photons, our research has shown over almost 300 some patients that nothing will happen, regardless of the total dose that you deliver, which is actually sort of stupefying to most people because we all thought it was just a cumulative dose effect and that it shouldn't matter just over 10 MV. But we found out that neutrons are the true issue. And so what's new at MD Anderson? One of our favorite jokes is that we don't like to be new, we just don't want to be in the news because we want to make sure that whatever we use, because we treat the most people all the time. I mean, all I'm doing, it's a factory of treating patients. We don't want to be the first to find an error. So it's super cool, and I really do mean that, super cool that we have brought in some new stuff at MD Anderson. This is groundbreaking. My chair, my former chair, I should say, Dr. Ibbett, Jeff Ibbett, who you guys should one day hopefully get to meet or at least Google him. He's the one that gave me these slides. He made up a contract with Philips Electa to bring in one of the first Electa units that is an MR combined linear accelerator unit to this country. A lot of other centers may have what's known as the ViewRay, where you have an MR unit coupled with a cobalt unit, which is cool, but it's cobalt. What happens when you bring a LINAC up in there? Hey, you know, better PDD. It's amazing. And the imaging people. I mean, if you really want to see something pretty, get ready. So you have this beautiful LINAC mounted on the gantry, surrounding the MR unit itself, and of course with the regular MR table, which is actually going to be utilized also for the delivery of the radiotherapy treatment. So first comes in the linear accelerator gantry, which it's the bigger donut outside. Then you can see where they actually put the housing for all the stuff for the electron gun and everything for the LINAC, and then bring in the MR unit. Notice the sheer size of this. And it was remarkable seeing the fact that they had to literally rip off a side of our vault to expose it to Holcomb Street so that they could bring this in. And finally, you start to see the facade come on, and this is what it looks like. So totally doesn't look exciting on the outside. You're like, I don't get it. What's the rub? Let me show you. Look at these images. This are volunteer images from the MR unit. And these are diagnostic MR scans on the right-hand side, for me at least. What I want you to know, we've been doing studies, there has been no discernible difference yet from the diagnostic imaging to that of what we're getting in the MR LINAC unit. What does this mean? This is the best that IGRT has to deliver right now. Finally, we are getting the kinds of images that allow us to see tumors with better visualization than we have ever in our history of, man and womankind. And so finally, we are able to have this beautiful imaging at the same time of treatment delivery. This does not mean you take the MR scan, then you wait, and then you rotate and deliver the LINAC on the LINAC treatment. No, people. I'm ready to drop the mic. This is as you're dropping the beam, you're seeing things change. And then guess what it does? Remember that whole talk, that spiel I gave you about adaptive radiotherapy? And I'm sorry to tell you, I didn't have these slides when I talked to you. That's why you're like, wait a minute, this is different. She changed it. I did. What I want you to know, it allows you to adapt as you treat. But the harder part, people, and I do mean that, is to know when should you change? At what point? And that's the scary part. We are now getting more data than we know what to do with. So it's really that bad. And it's at this point that we have to determine as a group and for site and for specialty, as we start to see things we've never seen before at the time of treatment, what do I listen to? When is this too much and beats my tolerance? Beforehand, it was easy. If the tumor moved 5 millimeters, stop beams, change the setup, make the patient stop. That was easy, but now, oh my gosh, you don't know what to do with all this new information, but it's really cool looking at it. So Atlantic can use this image and detect the target in real time and simultaneous with the irradiation, allows you to localize all kinds of GI sites, and this helps me especially because we are just starting our SBRT pancreas treatments, and we've been doing it for a while, but we are updating them, and I'm telling you, this type of visualization helps me so much more because right now I'm doing everything with either CT on rails or cone beam CT. So for this unit, hopefully within at the beginning of 2018, we'll be able to translate everything that we've been doing on the True Beam unit over there. That would be really neat. And one cool thing is that, of course, MD Anderson isn't the only place that has this. 17 countries were represented at the most recent MR and RT symposium, and most of these countries actually already have at least one of these types of unit, whether it's an MR Cobalt unit or an MR Linac unit. And then what's even better than that, and I know you don't believe that there's something better than an MR Linac unit, because I didn't believe it, right? You really didn't. The PET Linac. Let that sink in. We all know that PETs are utilized to help the doctors identify where a tumor is. Yeah, you give FDG, you see wherever there's a lot of glucose. When the glucose and the FDG combine, what happens? You get those annihilation photons, and you know exactly where the tumor is. Bada boom, bada bing. But never have you been able to get it in such a quick time that you could actually get that information in a good enough time to then make a decision about treatment. But someone, not me, had the idea that we can work with the uncertainties and the inherent bad spatial resolution of the PET and have it so that we are getting that information simultaneously with treatment. So instead of just MR Linac, PET Linac is the next big jump. So in 2014, if any of you guys know Paul Keel, a wonderful Australian physicist, his team with Yang et al., they came up with an algorithm that they decided to help us do beautiful 4D type PET imaging with being coupled to a linear accelerator. They came up with this idea of how to have the gantry with a linear accelerator actually being put in a beautiful narrow slit in between the collimators for the PET unit. And they talked to a vendor. Reflection system. This is so cool, they didn't even put audio. Honestly, they didn't put audio. Now, does that make sense? Most vendors, they're trying to make money. They're like, let the slides talk for themselves. It's almost sinuous what's going on here. What I want you to understand is that that the most critical part of trying to determine what the tumor target should be, meaning the gross tumor volume that we actually contour for most of our patients, we like to have a PET CT scan. That lets the doctor know exactly where the tumor is. And the CT scan helps you know where in anatomy where that is. Oh, come on, don't buffer forever. Come on, let's see. There we go. And so once the doctor has that, they can clearly see where they intend to treat. Notice the beautiful blue Linac that's rotating about that axis there with around the unit, and notice you have the detectors for the PET scanner all on the side. What they're showing right now with the green laser beam happens to be the actual X-rays that are being collimated by those MLCs, just as tightly as what we have for the regular linear accelerators that we currently use. Of course, for this particular device, right now, it's been expected to only have one energy, just like what we have for our MR Linac unit of 6 MV. Everything else, I believe that it does have the capability of even giving you either MV CT type images or KV CT type images as well. So this is what it would look like in a hypothesized patient. Notice that they're showing how to treat multiple different sites. And guess what? They're all moving with respiration. So they're letting you know that this can do 4D PET imaging. And so even with treating outside of the lung, treating a liver lesion as well, they're saying that their system would be able to actually identify where these tumors are and treat them even while they are still moving with respiration. So here it's showing you how it gets the first acquisition of the PET scan. in the patients, both the chest and in the liver. Notice that the tumors are giving off that signal of the annihilation photons, showing this is where I'm at. Now, those same annihilation photons are going to bring about its very own annihilation. So the patient goes now into the scanner. Notice that they're giving off the photons from the FDG PET acting with the glucose in those tumors. And then after it's been detected, and you see only when there has been coincidence, notice the LINAC swings to that position and delivers the death blow at that spot. And it keeps doing that, raster scanning the entire patient until it is done. This is the coolest thing ever that I have seen and rat on. I know I've been using a lot of big terms, just saying a whole bunch of things like this, but I have to admit, I never thought I would see this day. And as of today, they are looking for centers that are willing to allow them to do research with them to show proof of principle, because they are all ready to bring their unit to someone and to get started. I'm not gonna put MD Anderson out as saying that they're gonna do that, so forgive the other slides that come up with YouTube. But what I will say, kind of interesting, but I will say this to everyone, in the next 10 years, we are going to see a big revolution in how we decide to treat patients, how we adapt, and the information that allows us to do that. Now to show you the newest thing that Varian put out, nothing like the reflection. In fact, it's like the opposite of the reflection, the opposite of the true beam, the Halcyon. And if you aren't familiar with Radonc, you're probably like, I don't know, that sounds like a really lovely place. What's the big deal about Halcyon? It looks just like all the other units that I just showed you, because it has the same nondescript gantry, looks just like a CT scanner. You see nothing different on the outside. What I will tell you is, just like what you were thinking, it is sort of the version of a simplified linear accelerator treatment unit, which allows for you to have both imaging and linear accelerator treatment all within one nice coupled device. It has a very simplified workflow, which allows for you to be able to treat people even quicker. You lay them in there, and you're able to do both the sim, the planning, and the treatment all in one session under 1 hour. This allows for people to finally be able to have the same kind of throughput like what we have at MD Anderson, with reduced costs, with reduced physics input, because there's it's limited in scope for all the directionalities that you can utilize the table for and everything. So it makes the commissioning process of unleashing this machine much simpler than what we have for our standard linear accelerators. So the commissioning is much more straightforward. Our planning experience has shown that this particular type of unit allows us to do only VMAT and IMRT, which is now the advanced standard of care for radiation therapy treatment. And it allows us to get plans that are complementary and just as good as what we have for our standard clinical cases in almost every single site. It even has the ability to do its own automated machine parameter check, because right now we have a number of different software and hardware that we utilize to verify all of the beams and all of the parameters for our machines, but it allows for you to have its own little automated system, which allows it to check itself. So it almost doesn't need as many personnel. We hypothesize that we'll be using this mostly for doing our palliative care cases, where we want to be able to sim, treatment plan, and treat all within 1 hour. This is especially useful for places that have reduced personnel and high throughput. So even though it doesn't have all the bells and whistles as all those other LINACs that I was discussing before, it only has MVCT and it only has one beam and so forth, it still allows you to be just as robust as 80% of the types of treatment that you would want to offer with a regular standalone linear accelerator. Why is this important? Why did Varian go out on a limb and bring us something worse than what they've already been pushing out for years? Because we have a global cancer epidemic right now. Finally, across the world, what we are noticing is that although we've done various efforts in keeping people alive in third world countries, guess what? They did keep on living. They've lived long enough to, unfortunately, develop cancer. And they lack the resources that most of the developed countries have in order to treat them. So imagine the inverse of all of those particle therapy maps and those MR-linac maps that I just showed you. All those places that lit up with particle therapy and MR-linacs, those are the places that do not need more physicists. Those are the beautiful green places, like where we are right now. Every place that's orange and red is in a radiotherapy dearth. They need the help of having the linear accelerators and the personnel with which to deliver treatment. So we need more medical physicists. And this is part of the reason why I go out and do outreach in the first place, because especially the groups like you. Why? Because you would be the factory that would feed us with more potential medical physicists. Being the educators that you are the first line of defense to actually decide who gets to know about opportunities such as these. So medical physicists, we're needed because we are the ones who will help to go about making sure that as these third world countries get these linear accelerators, which are being donated to them, that we have personnel who are qualified to make sure that they're being utilized properly and safely as well. So we need to increase our numbers. Right now we have about 7 billion people. Only 18,500 of us are like myself. So that means you only got about 3 physicists per million people. In undeveloped countries, you only have about 1 to 5 medical physicists per million. And of course, in undeveloped countries, you have none. So we have a huge need for a diverse and gender-inclusive group of medical physicists. So I present to you what I consider the most diverse physics subspecialty on Earth. Medical physics. And I hate to be the spokesperson and the example of it all in one, but, but so be it. So I'm not even gonna hide it. I want you to understand, everyone in this room, everyone should know that women are starting to outpace men in college. You've seen this across the campuses. And several studies have shown this. And when it comes to science, women are finally starting to close the gender gap against males. And what you've known in physics, about 20% of physicists, whether it's at the bachelor's level to PhD level, we are about 20% of the population getting those degrees. And then when you look at medicine, something special is going on. They're finally reaching parity. And what I love about this chart, and I'll show my age, it starts when I was born. So when I was born, there was very little chance that Julie would probably grow up to become a, an MD or anything, and it still didn't pan out, But at the end of the day, now, for people growing up in my situation and who come into the center now, you see the whole group of incoming medical students, you see 50-50 along gender lines. It is the most amazing thing and the shortest time span, just my lifetime, to have seen this occur. And after there's gender parity, the rest of the diversity issues would also follow suit. So I present to you what I believe the best answer. As you look at the people who are interested in physics, and when you look at the stats for medicine, what could possibly help to bring about something synergistically between what you see with the women's gender gap and physics and what's going on in medicine together? I present to you medical physics. In medical physics, and this is just 2002 and 2006 at UPenn, notice they already reached parity in their master's physics program. Now, of course, this is old data. You're like, well, Julie, that was 2002 and 2006. Who knows what it looks like today? Let me show you what's going on at my center today. And their undergraduate level, you did not see parity amongst physics majors, only 18% of which were women at that time, and were the same for faculty. But when you look at my particular center at this very day, you have 23% of the women being faculty members in the radiation physics department. I want you to understand, just because as a whole, physics maybe only has a certain number of women being part of physics, when you look at medical physics, our graduate students and our master's and PhD level students, they are all in classes where you have parity amongst the genders. In our board that actually directs the AAPM, the American Association of Physicists and Medicine, what I call your sister institute, what I will say is that we love women. In fact, Melissa Martin is right on top. She's the president of our organization right now. And when you look at AAPM, 25% of us who answered one of our studies in 2013 happened to be women. And why does this matter, that we have so many women in our particular field? It's because mentorship matters, and having a role model from your same group will help to ensure that you finish and that you then progress on to greater things. So a wonderful study done by the University of Massachusetts in Amherst, they found that just by having a woman-to-woman mentoring, you can help stop girls from dropping out of STEM. 18% of the girls who had male mentors, they still had mentors, right? They should have been fine. Guess what? They still dropped out. 11% of girls without mentors, they gave up. But none of the girls who had women mentors dropped or quit. There is something to be said about being able to relate with a person that you look up to, who looks back at you, and who then also grades you or them helps you connect with other people. And because my field is starting to see in all of our incoming classes, 50% men to women, we are now at a point where we have enough women to help reach back and make sure that our girls make it. So I present to you an option if you have any kind of desire to get some kids in your class, not just women, I'm not just pushing for women, all people, because I'm all about being inclusive. If you think they need help being part of a diverse team and they just want to know what kind of physics subspecialty to look at, just let them know about AAPM. I'm just saying. They don't have to leave AAPT, but they can check out our website. And it's very simple to figure out how to join us. In order to become a medical physicist, first you want to get your BS in physics or something very related, then get your master's, most likely just get your PhD in medical physics from one of our CAMPEP accredited programs. Then you also have to do a residency program because we're just like a true medical field. You have to get at least 2 years clinical experience in an accredited residency program. And then most importantly, you get board certified by a board such as the American Board of Radiology, which will include 3 specific exams, and the final of which is an oral exam, much like what medical doctors go through. If your students have any type of questions about which school to go to, if they're interested by any chance in becoming a medical physicist, please check out campep.org and look at all the different programs that they represent, which include 50 across the continental North America. And so pretty much almost every single state has a school with a CAMPEP accredited program. And then we got something new, everyone. Just in case your students don't want to get a PhD in medical physics, they're ready to get paid yesterday. We now have the actual Doctorate of Medical Physics, which is a professional doctorate degree at 3 particular institutions that are now CAMPEP accredited, which includes, hey, we're in the right place, Cincinnati. I don't know if there's anyone representing the actual city, but University of Cincinnati, University of Texas Health Science Center San Antonio, and Vanderbilt, which has the oldest school. And so the difference with the Doctorate of Medical Physics is that instead of the traditional PhD, which they're only showing study years here, which would take about 6 to 7 years, the DMP only requires 4, 2 of which is deductive training, which is the first 2 years of your regular PhD program, followed by 2 years of a guaranteed clinical medical physics residency. It is a done deal when you get the DMP. But the problem with the professional DMP is that it is a professional degree. So a professional degree, much like an MBA and a medical degree, what happens? You've got to pay. So that is the difference with going the DMP route. Otherwise, the traditional route, you get your medical physics PhD in a CAMPEP accredited program, and then you apply to residency programs, and you wait to get matched. The DMP, you don't have to wait to get matched. You are already matched at the time that you admit to the program. So it's a wonderful new option, and it's something that we, even at MD Anderson, are trying to start ourselves, and will hopefully start accepting students next year for. So at UT Health San Antonio, they roughly have about 15 or so applicants a year, and they have, as at this point, only had 1 graduate so far. If you'd like to let a student know about getting any type of summer training at MD Anderson, even within medical physics, imaging physics, or even outside, please check out our mdanderson.org website and have them look up their summer trainee program. We have summer trainee programs for students that I assist with from the high school level beyond, and they can have experiences both inside medical physics, imaging physics, and outside. As part of the AAPM Diversity and Inclusion Subcommittee role that I have, I also represent the DREAM program, which helps to bring underrepresented students into medical physics labs and centers so that they can get an experience to help motivate them to continue on to getting their PhD. If you have students that would be interested in that, or our regular fellowship program where they get a paid internship at these centers for 10 weeks with real medical physics researchers, please look up aapm.org. And so there's other specialties that are nestled within radiation oncology, such as radiation therapy, which is a program which allows you to actually run and operate our linear accelerators under the guidance of radiation oncologists and medical physicists. Notice the students here in the red little outfits. They happen to be wearing virtual reality goggles. And of course, before we actually let them get anywhere near a real person, we let them virtually learn how to set up patients and deliver radiotherapy under the guidance of their instructor. And so these programs are typically 2-year programs that they would start at the sophomore year of their undergraduate degree program, and this would allow them, after they finish, in order to start treating as a radiation therapist and to move up the ladder, which is also a very good, highly paid specialty. And on top of that, there's medical dosimetry. These are the people that come up with those treatment plans that I mentioned, either the IMRT, VMAT, and so forth. They also have a 2-year track program that we offer at our School of Health Professions that they can start after their sophomore year in undergrad. All of these subspecialties are available at centers, not just at like my own, but outside of us as well. And I believe that they're a close match to those people who may be interested in physics, but don't want to progress on to a master's or a PhD. And so the resources for all of those different types of programs and for more information, please check out these 3 sites, CAMPEP, AAPM, and astro.org to get more information on that. And as far as for where I got the slides for the medical physics degree steps, that was from Dr. Pagort's talk. And then a slide showing the work that I do for Science Night at MD Anderson from this past year's Science Night. Star Wars was the theme. So thank you so much for your time. And do you have any questions? It is very bright. I think I see a question right here.
Yes.
When you combine Linux and Proton with MRI, all I can think of is you got 1.5 centimeters of what's the sharp particle. My question is, what's the radius of curvature that you have horizontal, and is it small enough that can field well defined enough that you just essentially account for that?
So what you're talking about is electron return effect, and we have been actually characterized that in using Monte Carlo code in order to see how bad that is and how that impacts those beautiful IMPT plans that we were coming up with. But most of what we've seen when we look at Monaco plans of these patients who are in the simulated MR plus LINAC units, what we're noticing is that you're seeing effects that are small. When I say small, usually on the order of like 2% or less, that aren't actually going to affect how the actual dose targeting is occurring at the 100% prescription dose level. So we aren't worried about that. Is there some higher entrance dose? Yes, you do see that. But because the way that we treatment plan, meaning we spread the dose out by having multiple beams, we're able to actually work with that. And so because you're able to see where all the dose is coming from, if you know you have electron return effect at the entrance, you make sure you use enough beams so that you're spreading it around and reducing the total impact of that. So yeah, that was one of the first things that we were worried about.
No, I do have one question. I know the Japanese have been using a lot of carbon ion therapy. We all like to discuss in our physics classes medical applications. Could you tell us a little bit about the differences between proton and carbon ion?
Sure, I think I even had a slide which showed you just how much even nicer. Remember I said the thing about the hot knife in a, warm butter?
Yep.
Yes, let me see if I can find some of that warm butter for you. Give me, oh, don't stop there. There, good. So I believe that was right about, maybe this one. Should have been here. There's lung dose IMPT. I don't see one. Maybe I didn't have a picture of carbon specifically, but this chart here, which shows the entrance dose, there's actually one that's actually supposed to be the green. It's supposed to be the carbon ion. So if you look at the very interior, the proton is the red, and so you notice it has a higher entrance dose than that of the carbon. So because of carbon's unique characteristics, you're even better at having a lower entrance dose. And what gets us excited is not just about the penetrating capability, it's the lower entrance dose. When you know that you aren't gonna hurt the epithelium as bad, and you're not gonna end up with all the burns and everything, and wasting the useful part of your charged particle, that is what is key to us. So what you'll notice is that places like UT Southwest, I believe that they're gonna have a facility before us, which will allow them to utilize these. Because right now you do have to go to Japan and Germany and so forth, I believe Heidelberg, in order to get to use these. But get ready because the states are coming with carbon and everything, so it's about to be a nice little zoo of different charged particles that'll be utilized for radiotherapy.
So, okay, very good. Other questions?
I think this gentleman.
Over here, yes.
Two-part question.
Go ahead.
First part is for my students. What kind of money would they be planning on making? And the second part, for me, after you tell me this, how does somebody with a PhD in physics switch over to this?
Oh my God. Well, you're a bold man. Okay, so your students are getting ready to go to undergrad? And so if your undergraduate students right now are ready to meet up with me and say, Dr. Julie, I want to go and get a PhD in medical physics or a DMP, they can start earning right out of the gate over 100 grand. After they finish their residency and so, of course. When you go to the residency, guess what? You still get paid if it's not the DMP. If it's not the DMP and you do a regular clinical residency, the reason why they pay you is the same reason why they pay medical residents, because you are a low-level employee. They get all the work out of you and pay you only a quarter of what they pay the doctors. So they're still paying you 50 Gs. See, I put a number on it. You see that? 50 Gs is what they can expect to get for 2 years at least. And probably by the time your kids come out, it may be 65 or so. And then once they leave PhD and the residency and everything, then they should be making roughly about 120 on upwards. And so if the bigger the center, and I'll be very frank, the bigger the center is, the better the reputation, the lower they pay you. I'm not, it's very true, because they don't have to pay you because they have a great name and you have the support system so you aren't overwhelmed. If they work at a small standalone site that I do not recommend, they will get paid a lot because they have to do everything. But if you don't know much, you can't get much help when you phone a friend in another place. And then finally you had what's the second part? I think
After you said the large amount, how does he get into it? What would be the path? You already had your PhD.
So you have a PhD in like just pure physics, not to say just, oh, let me clear that up, in physics, not just like, you know. What would happen is you would try to contact any of our chair people for a medical physics program, let them know what you've done before, ask for which courses you can actually start to take and sit in on so that you can get in the scheme to be able to take the boards. That's what you need. And then once you take that coursework, see if they will then allow you to then apply into a residency program. Because you will still, according to the ABR rules, you need 2 years clinical residency, even if you already have your PhD. And so after you have that, then you can ready to take my white coat from me. Yes, and get that money, yes. Anyone else?
Okay, well, this is very great. Thank you very much. Okay, I declare this session officially closed. Thank you all for coming.